Welcome everyone to this session. We have a whole series this month. My name is Benjamin Washira with the Emergency Medicine Kenya Foundation. We have an entire series this month going through triage, both emergency primary triage and pre-hospital triage. Will be happening every Thursday evening from 7 to 8:30 p.m. East African time. And we look forward to an exciting discussion. And to kick us off on our series is Dr. Kimeu. She's one of our faculty at the Emergency Medicine Kenya Foundation, emergency care specialist, and yes, passionate about teaching, I think. So Pauline, over to you. If you have any questions, feel free to put them in the Q&A or in the chat, and we'll be able to respond throughout the process. But without much further ado, Pauline, go ahead.
Thank you very much, Dr. Washira. I hope everyone can hear me well.
Yes, we can.
All right, and thank you for that generous introduction. Yes, I'm Dr. Kimeu, an emergency medicine provider and an instructor at the Emergency Medicine Kenya Foundation. And yes, I love to teach about emergency care. So today we'll be discussing triage, a word that we are all familiar with, but today we just like to look at the nuances around it and to see how we can improve our processes in our facilities, as well as in the pre-hospital setting. This is a familiar scenario to all of us as providers. You've come for your morning shift, whether you're a triage nurse in a facility or you're an EMT, or an ambulance provider waiting for what the day may come. Some days are calm, some days they are overwhelming. Patients just flow in like a tsunami, as in this picture. And the question is, how do we see them? How do we organize ourselves? How do we organize those patients such that patients are seen and attended to in a systematic and organized manner? So this is where triage comes in. It refers to the sorting of patients based on specific criteria, assessing who needs care the soonest, in simple terms. Triage is a French word meaning to sort. So basically that's what the first responder or the first provider is doing, is sorting out the patients based on specific criteria, seeing who needs to be attended to first. So who can be attended to first? The criteria we'll look at very shortly, and who can safely wait in the waiting area. I know our patients, none of them like to wait, but as long as there are many people who need to be attended in a short while, some will have to wait. So this is the process of which they are sorted out, they are screened, and the people who need the most, who need the care most urgently are to first. So this is where acuity-based triage, it comes in. Acuity means urgency. Who is most acutely, who has the most dangerous symptoms, who is actually, just based on the criteria, who is very ill, who is mostly ill according to specific criteria, and that way we can sort out and classify each patient and get them attention as soon as possible. So why is this triage important? Like we have talked about, it makes sure the most critically ill, the most injured patient receives attention first. Creating systems ensures that you work based on guidelines, not on preferences, not on the way some of us have been doing. Some of our facilities, you say like, this is the way it has been, so I'm just doing that. We want to establish systems, proper systems in our facilities. So this is where now setting up these systems comes in. It helps to inform the resources required. If a patient is critically ill, do they need the emergency room? Do they need the most experienced doctor? Do they need specialists? Do they need special equipment? So this triage helps set up that and helps the providers to prepare for these scenarios. Ensures smooth flow of patients. So once you said, like I said, what systems will help have your department or your outpatient care organized. Patients come and see the first responder, the triage nurse or the EMT, and they are put and classified. And then now from there, we know who goes where at what time and who can wait. And it alleviates the anxieties of patients and that of the caregiver, knowing that they are in the system. Like we mentioned, patients hate to wait. But once they have seen the nurse and they know, okay, you have been classified as this, and on average, it takes this long to be attended to, then they know what they're waiting for, and it reduces anxiety, it reduces discontentment in your waiting area. Continuing on the importance, it identifies reassessment frequency. A critically ill patient requires reassessment almost, I would say, even every 5 minutes. If you have a patient, let's say with chest pain and respiratory distress, or even in arrest, that differing from a patient, let's say with an acute asthma exacerbation, who would require assessment maybe after each nebulization every 20 minutes. Then you do your nebulizations, let's say 3 an hour, and then you reassess finally at an hour and you see, is this patient okay to go home, or do we need some further management? That also differing to a patient who has come with a cut on the hand, they're attended to and they're discharged. So triage is really important in determining how frequently they are reassessed by the healthcare providers. It improves lines of communication. So once systems are established, you know, if I have an acutely ill patient, I'm speaking to the senior doctor in the department. If I have an okay patient who can wait, I am allocating this patient to this and this doctor. If I need someone else, if I need someone for wound dressing, if I need my colleague to administer some analgesia. So once you figure out where your patient lies, you can communicate with the rest of your team on what the patient needs and get assistance. Triage also helps monitor waiting time, which is very important especially in departmental situations. As head of departments and nurses in charge and doctors in charge, you should be able to monitor how long your patients wait to be seen. You should be able to know that in my department, an acutely ill patient takes this much time to be seen and should not wait longer than this amount of time. That's how you pick up, now the few patients that may fall out of the established system, but the system needs to be there in the first place. So that, a patient with chest pain requires an ECG within 10 minutes, that ECG needs to be reviewed by the doctor immediately, and that patient, if need be, needs to be put in the emergency room and treatment initiated within 20 minutes from the first encounter. So with those timelines, you monitor your waiting times and ultimately improve care for your patients. Provides an opportunity for surveillance and predictable conditions and ensures appropriate action. So once you're able to collect all this data, how many patients do you see on an average day? How many critical patients versus non-critical patients do you have in your department on an average day? How soon are they seen? Are all your resources? What do most of these patients usually need? Do you have a lot of TB patients? Then you need many isolation rooms. Do you see a lot of asthma patients? Then you need to make sure you have a lot of nebulization masks, lot of enough oxygen in your facilities. Do you see a lot of accident victims? Then you need to make sure your resuscitation and your theater and your surgeons are all on point. So collecting this data really ultimately helps improve overall care for your patients. So some of the fundamentals of triage, like we said, the basis is that the most acutely ill patient is seen first. Especially in government hospitals where some of these systems are not established, we see like it's a first come, first serve. It's who is the governor's cousin, so they must be attended to quickly. And I hope we can get to a place where that is no longer the case. Basic fundamental is the most critically ill is the first seen, and it's an objective classification. It's not about feelings, not about emotions, not about friendships. It's objective criteria that anyone can assess and categorize. So those are the basics that we need to think about. Quick categorization, setting timelines for patient assessment, initiation of treatment in a timely manner, and remembering that triage is a dynamic process. By dynamic, we mean that patient condition can change at any time. Someone may present to the facility initially critical, but when timely management and treatment has been started, after reassessment, you see there is improvement, they can be stepped down a bit. Or someone comes walking in stable, but at reassessment, you see that this patient is getting worse and worse, and care needs to be escalated. So this assessment does not end after the triage nurse has handed over to the doctor or the nurse that is particularly assigned to that patient. It's continuous assessment and intervention. We'll talk about that a bit later. So as we keep insisting, being the worst makes you fast, unfortunately, especially with how do I say, middle class patients. These are things they don't want to hear. But once you establish these systems and of course explain to your patients well, they will cooperate with you. So what should happen if the patient has arrived to you as the first provider, as the triage nurse? What should happen in your evaluation? So patient identification is paramount, using 2 names or even more if available. Date of birth and hospital registration number should be well documented. Take a sample history. By sample history, we mean the signs and symptoms that the patient is presenting with. Do they have any allergies to food and medication? What medication are they currently on? Past medical history, what illnesses are they on follow-up for? The things, hypertension, diabetes, thyroid issues, back issues. So all that should be captured in your sample history. Very important for females of reproductive age is their LMP. Last menstrual period, are they on any contraception or not? Are they compliant? All those details. The last meal taken is important, especially with your diabetics, your patients who say they are vomiting, they're diarrheaing, they're not able to retain anything. It's important to know when last were they able to take a meal. And the events surrounding now their presentation, what actually brought them to the hospital? Is it pain? Is it an accident? Is it worsening of symptoms? Is it just a refill of their prescription? It's important to capture all these in a brief but concise history. Then you, as the provider, take the vital signs: blood pressure, pulse, oxygen, temperature, and very importantly, blood sugar. Please let's improve and take it up that random blood sugar is a vital sign. Then don't forget their pain score. For many, almost all of our patients, it's pain that brings them to hospital. So ask them subjectively how they assess their pain, and there are tools to now objectively score them. And those a bit later. Then after you've taken your history, your signs, you have your vital signs, you'll be able to assign a triage level. So now you know this patient needs to be seen within 5 minutes or immediately. This patient can wait some 10, 15 minutes. This patient can wait an hour to see the doctor and receive some care. At the triage level is also a point to give appropriate health education. If we find abnormal findings in our assessment, maybe you record a high BP, but the patient is not known to be hypertensive. So this is where you advise and educate the patient about monitoring. Sugar, this is where you check for compliance of your diabetics. You'd remind them on food, on compliance, on follow-up, on checking, you know, like small things like wounds in their legs. This is the place where you provide that education. And then now clearly and carefully document all this. So yes, we've said we assign a triage level, but which system do we use? So many different systems have been developed. So question is which one? There is the ESI, emergency severity index, SATS, that's the South African triage system, MTS is Manchester triage system, SATS is Canadian. So if we just have a quick look at this chart, at the foundation, the principles are the same. The most acutely ill should be seen most urgently. But you see these small differences in just the naming. Some name by color, like if we check the SATS, blue is immediate, patient who requires immediate resuscitation. But you see now in the Manchester one, blue is a non-urgent patient. So that those small differences could bring some confusion. So this is where the WHO came in and decided to integrate all these components into a uniform and simple triage tool. So this can be used in a facility, in a hospital, in a clinic, or it can be used in a mass casualty incidents. I'm sure we've talked about mass casualties before, or even in the pre-hospital setting. Again, we keep re-emphasizing the triage is based on individuals' need of care and should be, and patients should be allocated a category based on their level of emergencies. So I'll share with this, I hope you can all see it. So there is a classification for above 12 years and below 12 years. The differences are small, but we'll just look at them. So for red criteria, these are the signs, like we mentioned. Criteria is what determines which patient is classified as what. So for your red criteria, if we start like any basic assessment, airway, breathing, circulation, disability. So what is signs that let us know this patient is not okay and needs to be seen immediately? A patient is not responsive. That is a patient that requires immediate resuscitation. Everything stops and we all rush to that patient. Patient is put in the emergency room, quickly put on all monitors, and resuscitation begins. Now, if a patient is not unresponsive, but in their airway, we have stridor. We have signs of breast distress, central cyanosis. Okay, what are some of the conditions that can give these signs? If I may involve now the whole, anyone who can volunteer. What is stridor a sign of? Airway obstruction. Thank you, Anne Macau. Okay, so is stridor a sign of asthma? Is asthma an airway problem or a breathing problem? Okay, we can look at that a bit later. Yes, Vera says no, it is not. Stridor can be a sign of choking, okay? But basically that is correct. Stridor is usually a sign of upper airway obstruction, either by infection, edema, foreign body, could be so many causes, but that is reason for immediate attention. Remember, if your airway is not okay, nothing else will be okay. So what do we do? 40-year-old male presents to the emergency room You're the nurse in triage. I'm still inviting volunteers. All right, so just to save on time, so securing the airway is paramount. Securing the airway is paramount. Depending on the level of obstruction, you may need to put an airway or you may actually need to intubate. So this is where clinical acumen comes in. Any features of respiratory distress, I said come again. So I'm saying features, when you have features of upper airway obstruction, it is paramount that you secure that airway. Airway management, I think we've gone through in other CMEs, but just very briefly, you may need simple maneuvers, jaw thrust, head tilt chin lift, or you may need to put an OPA or a pharyngeal airway. You may need to actually intubate. Right? So based on your patient, when you make now a more careful assessment, you decide what your patient needs and intervene immediately. Airway obstruction can kill in minutes. So this is not someone you allow to wait at all. Any signs of respiratory distress, you're assessing their work of breathing. If your patient is doing this, or you're seeing that they are tripoding, they're putting their hands on their knees, just trying to get more support. You're seeing they're getting tired, they're breathing so fast, their respiratory is almost at 30, at 40. That is a patient in trouble. You cannot breathe at that rate for long. Eventually you will get tired and you will stop breathing. So you need to intervene immediately. In the circulation assessment, simple things, just checking for cup refill. Is it more than 3 seconds? These are signs of poor perfusion. Do we have a good pulse? Can you feel it easily? Or do you have to really struggle to get that pulse? How do you have any signs of obvious bleeding? Is a woman coming after a home delivery and is still bleeding? Has the patient been in an accident and they're having obvious bleeding from wound? Those are things that need to be captured very quickly. Then when you put them on the monitor, how is their heart rate? Is it below 50? You're in trouble. Is it above 150? You're in trouble. So this is not a patient who is waiting, needs to be attended to immediately. If we look at disability, neurological status, any active convulsion, okay? What do we do with an active convulsion? Patient just drops before you and is actively convulsing. Anyone in the chat? Okay, so someone? Yes, ensuring safety of the patient in the environment. Very good, Vera. And then have them in recovery position. Excellent, excellent. Put the patient in recovery position, ensure that the environment is safe, they're not hitting themselves against anything. Then yes, Eric, I agree with you. Secure the airway after the convulsions. Remember, they bite their tongue. They are usually foaming at the mouth. So you need to make sure the airway is clear. You may need an OPA. You may need to supplement a bit of oxygen. And then now the main problem is the convulsions. So what do? What do we give immediately? Just one word: anticonvulsants. All right, whichever anticonvulsants you have readily available to you, administer immediately. So that's convulsions. Any indication of altered mental status, a stiff neck, that points to things like meningitis, persistent headache that is not responding to maybe the Panadols and the diclofenac that they may have tried at home. Hypothermia or fever, extremes of temperature also affect brain, and hypoglycemia. Remember also things like severe agitation. Okay, that's in the other. Yes, anything that affects your neurological status, that patient needs to be attended to immediately. So if we look at that box of high-risk trauma, we'll have a look at the criteria. What is high-risk trauma? poisoning or ingestion of dangerous chemical exposure. Those are patients who are not waiting. A threatened limb, we'll also look at that. Snake bites, acute chest or abdominal pain, something that needs to be very closely assessed, especially in patients who are 50 years old with the risk factors for cardiovascular events like an MI, STEMI, and STEMI, all those things. So this is where ECGs need to be done very quickly. The cardiologist or physician at hand needs to be notified immediately. Your aspirins, your atorvastatin, you follow the pathway for chest pain. That needs to happen immediately. ECG we've talked about. Violent and aggressive patients, either due to organic factors, psychiatric factors, or otherwise. These are patients you don't want screaming and shouting and potentially even harming the health providers. They need to be attended to immediately. Pregnancy, any pregnant patient needs to be handled very carefully. If they present with heavy bleeding, severe abdominal pain, seizures, or any form of altered mental status, severe headaches, visual changes, systolic BP above 160, diastolic above 110. Those are signs of eclampsia, preeclampsia, or inactive. You may just end up delivering that baby yourself, or a pregnant lady who's had any trauma. They need to be assessed immediately. So if you find any of that criteria, you move the patient to your high acuity or resuscitation room immediately. I hope up to there we are okay. It's a matter of assessing and categorizing your patient. So your patient comes and doesn't have any of these signs. You feel you can breathe a bit. So now we check for yellow criteria. The patient is a bit more stable, but still they're sick, they're unwell. So we see, what do they have? On the side of airway and breathing, do they have any swellings, any mass in the mouth and mouth, throat, or neck that could impede their airway? Are they audibly wheezing, or are they complaining of wheezing? So that could point to lower airway obstruction, and they still need to be attended to, but at least they can have some 10-15 minutes to set everything up. On the point of circulation, is your patient vomiting so much that they're not retaining? These are patients that are at high risk of dehydration and developing kidney injury. So they need fluid resuscitation quickly. Patient is unable to feed or drink. Severe pallor, you need to know, is the patient acutely bleeding, or has it been a chronic loss of blood? You need to assess that and capture your history very well. Is there ongoing bleeding, as we have mentioned? There are signs like recent fainting. Okay, those are circulation problems. You have some time to assess and intervene, but of course, we are not delaying too much. In disability, you have altered mental status that is not really as acute as for the red. An example would be, let's say, an elderly lady who's had a history of confusion for about 2 weeks. You're not panicking, you're concerned. That's what I try to tell my patients. We're not panicking, we are concerned. As opposed to the same elderly lady who presents with confusion or reduced level of consciousness in the past 4 hours. There's a difference, okay? And you need to clearly get that history. Hopefully they have some relatives around and know who needs to be attended in which way. Acute visual disturbances and severe, either body pains or severe headaches. Like I said, headache is a tricky one, and you need to know which are the dangerous headaches and which are the benign headaches. Other yellow criteria, we can say, like new rashes that have developed over hours. Remember, a new rash like urticaria, an allergic rash after exposure to either a drug that they're allergic to, or a bee sting, or a food that they're known to have allergies for, needs to be really assessed. If they're not in anaphylaxis, fine, it can be treated separately, but you need to really capture what kind of rash is it. Visible acute limb deformity, these are your swellings, your limb fractures, your cellulitis, your ankle strains, things like those. An open fracture, that when you don't want to delay too long, but you have some time. A suspected dislocation, trauma, burns, we look at the type of burns that are red criteria. Other burns can be considered as yellow. A non-diagnosis requiring urgent surgical intervention, like your appendicitis or cholecystitis. Sexual assault should be treated very seriously and urgently, but they have some time. You have some time, and by some time, I'm saying 10 to 15 minutes, not too long. These are not people to be kept waiting for too long. Acute testicular or scrotal pain, priapism, these are your sickle cell patients. Testicular torsion is a surgical emergency, so they need to be attended to very quickly. Acute urine retention, it's a urological emergency that needs to be sorted out very quickly. Exposure requiring time-sensitive prophylaxis, like we mentioned, animal bites, needle stick injuries. The prophylaxis is important so that they don't develop rabies, they're exposed to HIV, hepatitis. All that assessment needs to be done and treated accordingly. Pregnancy, if you don't have any of the red criteria, then you can assess. Sometimes, yes, they come with a simple UTI. Sometimes they're a bit nauseated. Sometimes they just need a bit of fluid. Sometimes they need a bit of reassurance. But you need to carefully assess each patient. So these patients falling under yellow criteria, they can be moved to your regular clinical areas. So after capturing your signs and symptoms, now check your vital signs. Your heart rate, is it below 60? Is it over 130? Your respirate. An adult with a respirate less than 10, we're in resp failure, and this patient potentially requires intubation. Over 30 would consider it distress, but with impending failure. Extremes of temperature, as we mentioned, they need to be checked. SpO2 less than 92, that patient needs immediate oxygen supplementation. And level of consciousness using a simple AVPU. Anything other than A requires very urgent attention. So if your patient does not fall under any of these, we can consider now moving them to low acuity area, and these patients are the ones who can actually wait to be seen by the doctor. I hope these criteria are clear. These are the normal signs that we assess for each and every day. We're just putting them together in an organized system so that we know, okay, my patient has red criteria, I'm resuscitating immediately. My patient has yellow criteria, I have about 20 minutes to see them. My patient has no red or yellow criteria, their vital signs are within normal, this patient can wait. All right. We had mentioned about high-risk trauma. Oh, sorry. So remember, this was a tool for adults or patients above 12 years. For the pediatric population, the basic things, the principles are the same, okay? Just minor differences. If we come here, yes. So an unresponsive child, immediate resuscitation. All right, that one we are familiar with. Airway, again, do we have signs of upper airway obstruction? Do we have respiratory distress or central cyanosis? Again, immediate attention. So for circulation in children, the assessment is the same. But you know, as children are prone to faster levels of dehydration, they also show simple things like just lethargy, having sunken eyes, very slow skin pinch or return of skin pinch, or very poor intake. That can mean our child is actually very dehydrated and requires urgent fluid resuscitation. For disability conversions, attended to the same way. For a child, it's usually a bit difficult to get them to know, especially a non-verbal child. But if they're confused, they're restless, they're continuously irritable, they're inconsolable, that's a child you should be quite worried about. Or even worse, lethargic. Children, I like them because they don't hide when they are ill. An ill child is an ill child. So a patient who was very active, playing around, and now is lethargic, is not interacting with his environment, is not playful, that's a child to be worried about. Signs of stiff neck, hypothermia, fevers. Yes, those are children that you should attend to immediately. Hypoglycemia can give altered level of consciousness. That's why we'll keep repeating that blood sugar is a vital sign. So that if there's known history of maybe type 1 diabetes, or the patient presents with persistent vomiting or diarrhea, they have not taken anything, this is something to suspect and quickly take a blood sugar. Any infant who presents within 8 days, please put in the resuscitation room. Ages less than 2 months with very high fevers or very low temperatures, let's attend to that patient in the emergency room. High risk trauma, we look at that. Threatened limb, we look at that. Common in pediatric population, testicular torsion, priapism. Yes, we connect them, assess them very quickly, connect them to the surgeons as needed. Animal bites, snake bites, but specifically snake bites, you want them attended to immediately. Poisoning or ingestion of dangerous chemicals. We always say keep medicines and chemicals away from children, but children are curious, so it's common that they swallow and expose or they pour on themselves dangerous chemicals. So this requires immediate attention. Pregnant, again, remember to keep in mind different cultures, different customs. So yes, someone may bring an 11-year-old wife that is pregnant. If they have any of the adult red criteria, remember we mentioned heavy bleeding, severe abdominal pain, seizures, severe headaches, high BPs, they need to be attended to immediately. Sorry, there's a question. I want to ask you if you will send me the slides after the training course, as they're important for revision. All right, so Robert Osoro, this presentation will be made available thanks to one of our sponsors, Daktari Online, and you'll be able to access it there. All our slides and this whole presentation. Under circulation in children, we also, those unable to breastfeed, very good. That is very correct, Yukabeth. Any small child who's unable to breastfeed, we consider that a red criteria. All right, so if your child, a patient under 12, not presenting with any of the red criteria, we look for the yellow criteria, many of them similar. Any swelling of the mass or mouth, wheezing, and a circulation unable to feed or drink, but these are for older children. A patient who's vomiting everything, has ongoing diarrhea, is visibly dehydrated and clinically dehydrated, has severe pallor with no, not from active bleeding or from an accident, you have some time to manage this patient. Disability, restless child, or a child in severe pain, you have some time to attend to, but please try and administer subanalgesia as quick as you can. Any infant, generally from 8 days to 6 months, with no red criteria, We have a few minutes to see them. Obvious malnutrition with severe wasting or edema of both feet, trauma or burns with no red criteria, cases of sexual assault, again, emphasis of the need to be attended to care with sympathy, with empathy, and with proper documentation of all the events surrounding that. Any surgical emergencies, rashes, animal bites we've talked about, pregnancy with no red criteria, and headaches with no red criteria. Those ones can move to the clinical waiting area. They can get some IV analgesics as they wait to see the doctor. Then again, check your vital signs. Remember, especially for the pediatric population, vital signs are relative to their age. So we as Emergency Medicine Kenya Foundation, we don't recommend memorizing. We encourage having blown up posters all over your walls so that anyone can quickly look and refer to see what is normal for a 1 year, what is normal for a 5-year-old. So if they don't have any alarming signs, then they can wait for, they can be moved to the low acuity waiting area. So I hope you've seen that the differences are minor. The principle is the same. Look for the serious life-threatening criteria and attend to them immediately, those who fit. So we had talked about high-risk trauma. Okay, so what classifies as high risk for both adults and children? For general trauma, we consider a fall from twice the person's height, penetrating trauma excluding distal to the knee. That would be either to the upper thigh, abdomen, or chest, or even the neck area. Those are patients who need to be attended to immediately. Those would classify as red. Crash injuries, polytrauma, like in what we see with most common motor vehicle accidents, a patient with bleeding disorder or on anticoagulation that is actively bleeding, or a pregnant patient who has been in trauma. Those are considered high risk. Specifically for road traffic, high-speed motor vehicle crash, a pedestrian or cyclist hit by a vehicle, other person in the same vehicle who's died at the scene. These are things that you capture in your history. A motor vehicle crash without restraint, patient was not belted, or trapped or thrown from vehicle, including motorcycle. So these mechanisms help you predict that this patient could potentially have very serious injuries and potentially life-threatening injuries. For major burns, I hope we have charts we can refer to on how to calculate body surface area affected. So anything greater than 15% is considered major or circumferential or involving the face and neck. That is a patient that you attend to immediately in your emergency room. Inhalational injuries. What is so dangerous about inhalational injuries? If someone could respond in the chat. Why do we always ask about inhalational injuries? What threat do they pose to the patient? Airway issues, airway edema, swelling of the airway obstruction. Very correct, very correct. I'm happy we are aware of this and we actively look for it. If someone could tell us, what are some of the signs of inhalational injury? What are the signs that we look for? Singed hairs, very correct. Soot in the nasal hair, very good. Facial burns, very good. Burnt face, very correct. Soot around the nose, very correct. Something in the history, burnt eyelashes, very correct, Benjamin. Carbonaceous sputum, that is correct. Hoarse voice, stridor, very good. Something in the history in a closed room, very good, Feli. if a patient says or the report that is given is that they were in a closed room during the burn, that's a patient you should suspect of having inhalational injury and attend to immediately. Remember, we need to secure that airway. Very good. So about burns, any burns in a patient with extremes of age, either less than 2 years or older than 70 years, those are patients who can deteriorate very quickly as their compensatory mechanisms, they're either not developed or they exhaust very quickly. So they need to be attended to immediately. Threatened limb, these are limbs that are injured either in an accident or in a crash injury or in an assault, depending on the mechanism. So the most important thing is to assess your pulses. I hope we all know how to assess pulses and we know where all our pulses are. That is an easy exercise that you can practice on yourself. So if a limb is pulseless or is painful, if it is pale, if it is weak, if it is numb, or with massive swelling after trauma, that is a threatened limb. Remember, our red criteria is we suspect either threat to life or limb, all right? So let's not forget to assess our limbs very closely. Other high-risk criteria, signs of respiratory distress, very fast or very slow breathing, inability to talk or walk unaided, a confused, sleepy or agitated patient, use of accessory muscle use, neck, intercostal or abdominal, those are signs of respiratory distress. What do you think is happening with a patient who comes potentially, he comes confused, he's very agitated? What are some of the things you'd think about? No pain, no fall, just presents, let's say, let me put it clearly. 43-year-old male, yes, presents to the facility. The relatives have brought him, he's fighting everybody, he's speaking his own things. When you ask about comorbidities, he says, yeah, he's non-hypertensive, he's non-diabetic, but he's been taking his medication. Yes, he's just been having a cough for a few days. Yes, Anne Macau says hypoxia, very good. So hypoxia, remember hypoglycemia too can give altered levels of mentation. Very good, Esther. Yes, always check your sugars. Always check your sugars among your vital signs. So for the child, the same. And always for a breastfeeding child, ask if the normal frequency has changed. The mother will always know what is normal for that specific child. Things like nasal flaring, grunting, those are very obvious in children. Let's be assessing for them. Poisonous ingestion or exposure. Hopefully, most of the time, some don't even know what they took, some do know and they're able to bring the containers, which is excellent for us. So any signs, you need to really assess that patient specifically. Are they persistently vomiting? Are they vomiting blood? They're urinating blood, they're conscious. You need to assess what your patient has to determine what your patient has and how soon they need to be seen. So I hope on criteria we are clear. And these are charts that are available on our website that you can print out and have in your triage room so that no one is memorizing anything. Anyone can do triage. Triage is not limited to nurses, and I hope we don't limit it to nurses. Yes, they are the forefront. They are usually the first people to see the patient, but anyone and everyone should be able to accurately triage a patient. All right, so basically, like we've said, that's the integrated triage tool. Yes, so important interventions at triage. You've received the patient, you've assessed the patient, you've categorized the patient. Even more important than all those will be what you do. you've decided this patient is a red patient. What do you do next? Okay, so let's go back to our patient who had stridor. Nothing else, just stridor. And we've accurately said that that's a sign of upper airway obstruction. So how do we intervene? Do we say, we waende kwa daktari? Or is there something that you, as the first person to see that patient, you as the nurse in triage, that you're able to do? Okay. So nebulize with adrenaline, correct airway. Okay, how do we correct that airway? Our patient has stridor. Our patient is an adult male, says he's been having a serious, he ate some nuts somewhere and he feels his throat is tight. He's not able to breathe properly. Okay, so simple maneuvers, head tilt, chin lift may work depending on your level of obstruction. Okay, so let's say, Esther, you do that and it's not helping. What else can we do? Heimlich maneuver. So let's say our patient is currently not choking. Inspect for any foreign bodies. Okay, if you're able to do. Esther says intubate. Eric says adrenaline 0.3 IM. Vera says use your airway adjuncts. Yes. So one thing I would also like to remind us is that healthcare is teamwork, all right? Especially when you identify your patient as a red patient, you quickly escalate and you call the rest of your team to join you. So rightfully, as you've said, as one patient, as one provider is putting your airway adjuncts and OPA, someone else is quickly getting adrenaline and giving the injection, as another is now setting up for rapid sequence intubation. Very good. So we are not being superheroes, but you're doing everything almost simultaneously. Remember, we are trying to save the patient's life together. So it's teamwork. Escalate, quickly get everybody involved, get the experienced, most experienced person with intubation involved, secure that airway. Very good. So if the patient needs to be suctioned, those are easy things that can be done immediately. All right, so that's airway. On breathing, simple assessment, we look for signs of increased effort of breathing. Like we mentioned, use of accessory muscles, posturing, looking for a foreign body in the mouth, listening. Are we having abnormal breathing sounds? Are we having abnormal distress? Auscultation, what do you hear in the chest? Is it ronca? Is it crepitations? Is it a very loud wheeze? Is it reduced breath sounds? You need to listen. Feeling, how is that chest? Is it tender to palpation? Are you seeing crepitus? Are you able to feel areas of abnormal chest wall movement, as with rib fractures or even flail chest? So you need to thoroughly examine your patient. Giving your patient oxygen, give oxygen, give oxygen, give oxygen. I'm happy the Emergency Medicine Kenya Foundation has been so proactive in setting up oxygen manifolds in various facilities across the country. So I hope we have enough oxygen and that we are generous in giving it to our patients. Vital signs are less than 92. Our patient has increased effort of breathing. Our patient has reduced breath sounds. Let's give oxygen. I hope we know how to use the different oxygen devices. We know who gets a nasal cannula. We know who gets an oxygen mask. We know who gets a non-rebreather, and we know who, on whom to use a bag valve mask. All right. I hope we know all those. Attach your SpO2 monitor. Like we said, it's a dynamic assessment. So your patient needs oxygen, you've supplemented your oxygen, you're checking your monitor. Is it enough? How is the patient responding? Are they more comfortable, or do they need a bit more? Do we need to escalate to the next step? So at this point, it's very important to know who needs what and what goes where. At the point of circulation, we need to stop, obviously, active bleeding, okay? I know with bleeding, we usually think of, big wounds from accidents, but let's look at something simple like nose bleeding, okay? As the nurse in triage, what do you tell the patient to do? The patient comes, the nose is dripping blood. How do you advise your patient? Or what can you do as the nurse in triage? In the chat, you tell them to pinch their nose. Very good. Okay. Anyone else? Okay, Yukabeth. Pinch nose, sit with head slightly tilted backward. Okay, does everyone agree with that? Which way do they tilt? Backwards or forward? It's forwards. All right. So what we don't want is okay, you've corrected yourself. Yes, forward. So we don't want the blood going back to their throat and potentially having them swallow the blood that will irritate their stomach and have them vomiting. So we want them to lean forward. Yes, they pinch their nose. Yes, if all those basic don't work, then they have time to be seen and have the adrenaline gauzes packed in their nose. Very good, very good. So these are things that can be done very quickly as you set down the patient to sit comfortably in a room, waiting for the doctor. A patient with a C problem should always be on, basically any red patient, any patient with red criteria should always be on a monitor. Should always be on a monitor with full monitoring, having their BP, their heart rate, their oxygen, their temperature, their breathing rate. All those should be continuously monitored. If a patient requires fluid resuscitation, which C problems, yes, you need fluid resuscitation, sometimes blood. Obtain that IV access very quickly and very early. Use the biggest cannula you have. And in cases of like severe trauma or polytrauma, you actually need 2, okay? Even in like heavy bleeding PPH, those ones you need 2 cannulas. You better have them before now your patient is so dehydrated or has lost so much blood, the blood vessels constrict and you can't get another line. So immediately that patient comes, the biggest cannula you can get, and if need be, even 2. Try and collect blood samples as you insert the cannula. Try to avoid pricking the patient so many times, but where possible. But just collect the blood samples very quickly. Then as you figure out what is happening, you'll figure out what to order and what the samples can be sent to the lab. Remembering blood sugar is a vital sign. Blood sugar is a vital sign. Your fluid resuscitation, simple normal saline, simple Ringer's lactate. Those are what we advocate for. Yes, have your fluids, have your fluids ready. Where available, have them warmed. I still remember this very funny story when I was in internship. It's the evening, you've done rounds, you're tired, then the nurse is calling me. All the patients in the ward, they're reacting to saline. I'm like, what do you mean? You can't react to saline. They're like, they're all shivering. They're reacting to saline. I'm like, hey, what is going on? Let me come and see. So I come and see, and for sure there was a section, you know how the cubicles are. So like 5 or 6 patients are all just shivering. And for sure they're all receiving fluids. So I'm like, it's not possible. They have different diagnoses. They came with different things. How come all of them are shivering so badly? They're not in pain. They don't have rashes. They're just shivering. Long story short, the fluids had been kept by the window in a cold, rainy Kericho afternoon. So those fluids were so cold. We were basically driving the patients into hypothermia. So small things can make a difference and affect your patient's outcomes and your patient's morbidity. I see a question from Yukabeth. Fluid of choice, use of hypertonic saline 3%, Ringer's lactate. All right. Fluid of choice, we usually start with isotonic. Whether you, and we simplify that to what you have available. Overall, normal saline versus ringers, not much of a difference with outcome. The difference is with their components. Ringers is a bit closer component-wise to blood plasma, but that's normal saline. Hypertonic saline is used in very limited indications. If you have diagnosed hyponatremia, or you're thinking about increased intracranial pressure, yes. Specifically, hypertonic saline has very limited uses. On a normal day with your vomiting, diarrhea, hypotensive patient, please use normal saline or Ringer's lactate, whichever you have. I hope that one is clear. Yukabeth, have I answered you? All right. So your isotonic fluids, whichever you have, if possible, use Ringer's lactate, it's closer. Only in very specific indications would you use hypertonic or hypotonic saline. All right. So other small things like if you've diagnosed your patient with acute asthma exacerbation, nebulize them. I believe all our facilities we are able to nebulize. ECG for chest pain. ECG for chest pain. I hope we are comfortable reading ECGs. Am I ECG near daktari? How many believe as nurses? Let me speak to the nurses in the audience. Nurses, are we comfortable with ECGs? Just type yes or no. Shadrach, thank you. Yes. Oh, this is very impressive. Partially, okay. That is good. Jacqueline says yes. Can read a few, still practicing. That is the only way to get better. We just keep practicing and practicing and practicing. I'm happy that our nurses are even just a bit confident at reading ECGs. Remember, we're not trying to be cardiologists. We just need to be confident in the normal. Then you'll be able to know this is not a normal ECG, and then you escalate it to maybe your senior doctor on duty, or if you have a physician or cardiologist available, you quickly take a picture. Thank God for WhatsApp these days. We can quickly send them and have them interpret it for you. Then you will know, is it a STEMI, is it an NSTEMI, or does the patient just need further evaluation in clinic? But I'm happy to hear our nurses are at least quite confident with ECGs. Additional fluids for shock. So, and DKA, DKA is a whole topic on its own. But I hope we have our algorithms that we can always refer to when we get some of these situations, so that you know how much fluid to give, when to give, and how to keep where is the end of your fluid resuscitation. Anaphylaxis, we've mentioned it, that you need to give your adrenaline very quickly. Analgesia, like we said, almost all our patients come to hospital because of pain. So let's generate analgesia, assess the level of pain for the patient and give analgesics accordingly. Antipyretics as well, fevers are very uncomfortable, and especially in children, very high fevers can even lead to convulsions, so we need to lower temperatures back to normal. Anticonvulsants, we've talked about convulsions. Yes, we are not having a seizing patient wait. We are intervening immediately. Urine PDT for pregnancy. I know in our setting, most patients wait, like they wait to see the doctor, then the urine is ordered. I hope we can get to a level where all patients suspected of being pregnant and collect the sample even at, I mean, it's urine. If you don't need it, you don't need it. But the earlier you diagnose that pregnancy, the better. Remember, any young female of reproductive age complaining of abdominal pain has an ectopic until proven otherwise. And an ectopic pregnancy, a ruptured ectopic pregnancy, is life-threatening. So that's not something that can wait for. So the soonest you can get that during PDT, the better. Fractures and dislocation, immobilization, those are things, the basic immobilization, we know how to do. Even in the hospital setting, if you arrive at the scene, you're able to quickly immobilize a fracture before now referring for further management. So I hope we are not just allowing patients to walk around with broken bones and yes, swinging limbs anyhow. Okay, let's just basic slings, basic splinting. If you have the fancy immobilization splint, then good. But splinting is a basic and simple and quick procedure that should be done from triage. Now, about high BPs. We have spoken so much about high BPs. What were oral nifedipine? Yes, why do we not give antihypertensives for a BP of 160, 170? Why do we advocate do not give oral, it's even rewritten even in caps, do not give oral hypertensives. Byron says in our set, we normally give oral antihypertensives because we don't have intravenous. For which patients, Byron? Do you give with some evidence or do we give because you've recorded a BP of 190? A systolic of 190? The others may answer as well. Which patients do you normally give these oral antihypertensives to? Anybody? Okay, let me quickly answer for the sake of time. So for high blood pressure, please investigate for evidence of organ damage, okay? This, I think, can be a separate CME on its own, but don't rush to give oral antihypertensives. That BP has not risen in the 3 hours before they came to you, okay? Risk of stroke. If they have not actually presented with a stroke, investigate, assess for signs of that stroke, okay? Strokes don't keep quiet. Assess for signs of that stroke and have evidence of actual organ damage. By organ damage, you're talking about the kidneys, the heart, the brain. Yes, before you rush to give those antihypertensives, because what normally happens is that we very rapidly reduce those blood pressures, and then we end up taking them into ischemia because their bodies are used to BPs of 190s, and then now you're insisting on it being 120, which is low for them. But I think Dr. Ashira can plan for a specific CME and a webinar concerning hypertensive and hypertensive emergencies, hypertension and hypertensive emergencies and their management. Gastric lavage is another interesting discussion. So current evidence does not support regular or constant use for gastric lavage. Unless the patient has presented to you within an hour of ingestion, which rarely happens, you do not need to give gastric lavage. By the time they come to you, the poisons have already been absorbed. So your gastric lavage has little benefit to that patient. In turn, you're increasing the risk for aspiration, for damage to their esophagus and stomachs with invasive procedures. What you need to do is assess secure airways, and after you've determined what the patient has ingested, manage now the treatment. But again, this needs to be discussed further. Let's not be rushing to give everyone a gastric lavage. So with that, I hope I have empowered all of us, but especially the nurse in the triage station, that there is so much you can do in that office. It's a very important office. I remember we were taught that usually we end up posting or assigning the least experienced nurse, the new nurse to triage when it should actually be the most experienced nurse at triage. The nurse who can look at a patient and very quickly know this patient is in danger and requires immediate attention. So with experience, of course, you can be able to do this. But meanwhile, let's practice systematic assessment, systematic identification, assigning of where the patient needs to be and how soon they need to be seen. And immediately, the nurse yourself, you're able to intervene with life-saving interventions for these patients. Thank you. And it's a cycle. We keep reassessing and escalating as needed. Thank you very much. Now, if there are questions, Dr. Oshiro, if you have any contributions.
I think I see some questions online about nebulizing with Combivent. Just how do you nebulize patients with Combivent?
Are you asking about the doses, Angela? So doses you can always look up. I think even the Combivent himself comes with instructions.
She was asking about dosages. So it depends. Again, as Pauline has said, you need to check up your dosages. So it's either an adult or a child, the doses will vary, but your nebulization solution ideally should be topped up with saline to last at least 20 minutes. There's a question around gastric lavage. What time frame is suitable for lavage or not?
What time frame is suitable? So usually, wait. It's activated charcoal that we say 1 hour. Really, gastric lavage is no longer recommended.
Yes. No one, you should not be lavaging anyone. Totally agree with you. No one should be getting gastric lavage in this time and age. But yes, the charcoal should be given within 1 hour or can be repeated. So all of this, again, if you check the poisoning pages in the protocols that we share in the casualty app, you should be able to find the answers. But thank you. Let me see if there's any other questions. A patient presents with acute liver failure secondary to alcohol with hypertension management, please.
That's a bit specific. That one, again, back to basics. What red criteria do they have? Or do they have yellow criteria? Then now you escalate to your doctor to now address specifically what's going on with that liver.
Yeah. So the first, someone with liver failure, your first concerns, of course, are issues around hypoglycemia because glucose is mostly metabolized in your liver, and if alcohol also does promote hypoglycemia. But then you have your ABCs in terms of stabilizing the patient. In this particular case, your hypertension is not your problem. You have bigger problems to deal with. Yes. So there's always a knee-jerk. Yeah, as Pauline said, there's always a knee-jerk reaction to deal with blood pressure. Most of the time, that's the least of your problems. At least a good chunk of time, the patient's hypertension is not your biggest problem. It's potentially their pain that is causing that high blood pressure. It's their underlying conditions or the damage that the pressure is causing. But in which case, again, most of the time, the intervention is not something that needs to be done like with a tablet. It's a slow process of dropping down the blood pressure. Check out hypertensive emergencies in the emergency care guidelines that we supply. You should be able to get them there. The how to manage hypertension.
The only other emergency I would think of with liver failure is acute bleeding.
Yes.
So if they're not having like variceal upper GI bleeding, or because of their low platelets, they're not having like brain bleeds, really they have some time. I think they have some time.
But thank you very much. I think one of the key things that Dr. Kamel has highlighted is triage is not just about coloring patients. Triage is about identifying the patients which patients need what intervention and what urgency of the intervention and starting the intervention. So we need to make sure that's why triage cannot be done by the watchman or the untrained staff who's readily available. Ideally, you want the most qualified healthcare provider available to do triage to ensure we need to stop patients dying in the waiting area waiting to see a doctor. If you have ever had a patient dying in your waiting room before they saw a doctor, you really need to look at your triage processes. Triage, with an appropriate triage process, no one should die waiting to be seen by a doctor. People, yes, should be picked up early as emergencies. All right, so Pauline, over to you to wrap up.
Okay, so our talk today is really about, even more than the knowledge of knowing how to categorize patients, is about creating that system and enforcing it. Let that be the norm, that this is how we assess our patients as they come in, whether during the day, whether during the night, that system. Establish a triage system. You can see the material on our website, emergencymedicinekenya.org/triage. The handbook is there with all the information. A simple patient triage record is available. You can print and use it for your documentation. We talked about posters that you can blow up and put them on the walls of your department for easy and very fast reference. And you can even attempt a triage quiz for practice. It's free of charge, easily, freely accessible. But the idea is to actually implement that system and practice triaging your patients and reassessment. That is what I would think.
All right, cool. All right. We thank you very much, Dr. Kimel, for joining us this evening, which was really informative. As she mentioned, you can get access and you can try out the triage quiz. If you pass the quiz, you get a certificate from it. So go to the website and try out the triage quiz and see what happens with that. And then we'll have another session. Remember, we're having a session every Thursday evening from 7 to 8:30 p.m. in the evening. This whole month, discussing different levels of triage. Next week, we discuss pre-hospital triage. So looking forward to seeing you all next week for the pre-hospital triage session.